Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by Village MD, primary care physicians. Practice medicine the way you've always wanted. Data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel of Village MD, and I'm here with our podcast executive producer, Janessa Nelson.
Hi, everyone.
You're so much more than an executive producer, but I will say you did shoot me down on my idea to do reaction videos today.
I mean, Wendy, there's humor in everything, but these are people's livelihoods. So we want to be a little bit more professional, but I do think that we learn a lot of lessons from these cases.
Yes. We look at indictments, and we're covering today some recent trends in enforcement in the Medicare Advantage program. We learn a lot from watching enforcement. And so that's what we're going to share with you today, is what can be learned from the activity that we're seeing in these areas. So let's go ahead and get into it because we have a lot to talk about. I think it's important to just give some context here. So we always talk about how Medicare payment has evolved over time. And as a result of that, enforcement has evolved along with the changes. So we know that when Medicare began, there was payment for services.
So I go in to see you, and then you have me pay for what you did, right?
Right. The payment was because I performed a service. And so naturally then a false claim was a service that I didn't perform.
Got it.
And that's what got us in the physician world into the world of documenting with such detail what level of visit was performed, because a false claim would be I billed a 5 and I only did a 3. And so now payment has evolved, and it's not payment for a service. The payment is based in part, at least, on how sick is the patient. And that makes sense because the idea is you're going to need more time if the patient is sicker. So we saw that originally start in the hospital DRG world. What's weird about that is that an overpayment then is you've inflated how sick the patient is. So in a DRG, overpayment is you said the patient was sicker than they were. And so that takes us down this rabbit hole of confirming clinical diagnosis information on a patient. And that is always weird because it's really up to a physician treating a patient to determine what the patient's condition is. We put all these coders and all these support. That's where we ended up getting into this clinical documentation. That hasn't really affected physicians all that much until now, physicians that are practicing outside of the hospital or a nursing home. But in the Medicare Advantage space today, after it was revised somewhat in 2010, and now it's proliferated with the HCC codes, those are clinical acuity codes. And the government believes they're being inflated to the tune of billions of dollars of overpayments. And enforcement of those gets us into this weird place of looking at a patient's diagnosis. And what you see, and the trend you're going to see in these cases today, is that whether or not they ever say it, the suspicion that arises in the case of these cases is when the government believes that there's processes in place that don't come from the physician putting a diagnosis on a patient from a face-to-face visit. And that's usually where we go off track in some of these indictments, which you'll see today.
That's helpful context. There have been a number of cases over the last several years related to MA enforcement. Is that right, Wendy?
That's right. And we follow these in such detail. We do a summary of every case. We do a chart. We study them. We decided to spare our audience the details of the chart. But just the thing to know is this enforcement is hot. The OIG just recently published a report. They believe there are billions and billions of dollars in false claims here. And at Village MD, the legal and compliance department is really on top of this, and we're watching this closely. And we're going to tell you the things that you need to know today.
And 2 of these have appeared in 2020, right, Wendy?
Yeah, we've seen a couple new indictments and several OIG reports as well.
Okay, so let's just jump into it. So what's the first case?
The first case is an Anthem case. We've been watching it for some time, and we'll call it the case of the retroactive chart reviews. This case is a little unusual because there was no whistleblower, so we're not exactly sure and don't know how the DOJ became aware of this. But the DOJ began an investigation of Anthem in 2016, and we know that because Anthem has actually been in court before they were indicted, which is obviously unusual. And just, pro tip, doesn't usually go well when you're fighting with the DOJ about the investigation. It doesn't usually end well. It's like fighting with the refs,
Don't fight with the DOJ.
It's a bad sign.
Yeah.
So we weren't surprised to see the indictment come through this year in March. And what we can tell that's happened is between the investigation and the indictment, that's 4 years. And there's reams and reams and reams of documents that have been reviewed. They've deposed many of the staff just as part of the investigation. And they deposed, the compliance and audit personnel, et cetera. The practice that they were looking at, that they were bothered by, was a practice where Anthem hired a third-party vendor, and they used software to do a retrospective audit of their MA members. When they did that, the vendor identified codes that were missing, so that would enhance revenue. They also identified codes that were wrong. And Anthem had that information, allegedly, did not fix the ones that were wrong, but only put the booster codes in.
Wow. So this is essentially, it's not a two-way audit, right? They're only doing things to improve theirs.
That's exactly right. And that's really the key thing to know, is that we at Village, and everybody should, do quality checks of your codes.
Mm-hmm.
And that means that you're checking what's right and you're checking what's wrong. It's both ways. The other thing to know here is that the other thing that's sort of a cringer is, because this was so lucrative, the finance department would refer to it as a revenue booster.
Whoa.
Yeah. And so that's always a red flag and the cringer thing that comes out when these cases. And it's just something that, it's easy to, as we said, at some point, diagnosis, which is clinical, gets wrapped up with revenue. And so it's easy to start to refer to clinical diagnosis as relevant to revenue. And that's just something that we always want to be so sensitive about and careful with every time.
The other big thing that I'm seeing from this case is that Anthem actually had a policy that said that they weren't supposed to do one-way audits.
Yeah.
Is that right?
That's right. That's a bad day when the compliance officer and the auditors and so on are reading their policies in the deposition and admitting that they weren't followed. Yes. That's a day to be avoided. Correct. So the Anthem case is still pending, but the key issue there is these retroactive chart reviews, and a lot we can learn from that, and we'll continue to watch that one.
Got it. So I think the next one that we should look at is Cigna just got indicted in October. So can you tell us information about that one?
This is a new one and very interesting. The timing of this was serendipitous because in November, we got a report from the OIG about the kind of conduct that we see in this indictment. In this case, the conduct in question was Cigna began doing in-home risk adjustment visits. Now, before I say anything else, I want to be sure to clarify that that is not inherently problematic.
Got it.
In fact, we believe at Village that in-home care for chronic patients is so important and valuable. So I don't want anyone to misunderstand that in-home visits are a compliance. They're not.
So what did they do wrong?
The specific components here, there's a couple things. One is the visits were only for the purpose of diagnosis.
Oh.
And in general, that's never going to work when you're working with clinicians with integrity. They're never going to be interested in just diagnosing patients. And they're always going to raise the flag on that. And that happened here.
So they would diagnose a patient and then wouldn't do any care plan.
And that's it. There was no treatment from what I can tell from the indictment. Now, again, I'm only reading the indictment. We haven't seen a lot of the other filings and things. So this is all allegations, but that's the way it appears. So that's the first problem. And the second problem is they create, and this is so easy to do. It's easy to look at a case like this and go, oh, well, obviously. But it's actually easier to do this and have a problem than you think on this. Is they created a form. Someone created a form. Here, use this form when you're doing these risk assessments. And there were all kinds of problems with the form. Why? Because diagnosis is something that's very hard to put into a binary check the box type of form. And so many times, and we've seen this in the evolution of clinical documentation enforcement in hospitals, the second key thing that they did that was problematic is they created a form that was designed to support the clinicians in reporting the diagnostic information. This is easier to do than you think. It's always easy to look at these cases in hindsight and go, well, obviously you can't do that. But we've learned these lessons 100 times over in the hospital world with DRG coding. And the thing is, a form can be interpreted by the government as falsely inflating codes. And so every time we create forms and tools and things like that, we've got to make sure that our physicians are behind the form and that the compliance department sees them as well. In this case, it was felt that the form inflated the acuity. And that was for two reasons. One, it didn't differentiate between what was a patient just reporting and what was actually validated as a diagnosis. And there were some other binary things in the form where it was like a check the box. And the clinicians were raising concern, and they will every time. They were emailing, they were creating documents that said, this isn't right. And that wasn't heeded allegedly by Cigna in this case.
And that's where we ended up with a whistleblower in this case, right?
That's exactly right. Most of these cases have a whistleblower. The Anthem case is unique. But in this case, one of the providers that was being asked to do this felt it was wrong and brought it forward to the government.
Wow.
And so the advantage we have at Village is we work so closely with our physicians. But the key thing to know at Village is our physicians are responsible for diagnosing patients. And that's how it should be. And if we follow that, we won't have a problem.
And also, don't just diagnose, also figure out how you are going to treat or care for that condition, right, Wendy?
Well, the point that I made about physicians would encompass that.
Okay.
Because if we're working with physicians, they're never going to do that.
Mm-hmm.
They're always going to be concerned about the clinical care. Where you go off track is when you're looking at this from a standpoint of a payer or finance or something like that. And it starts to get away from the fact that these are clinical conditions.
That's an excellent point. So I think our last one is around Beaver Medical Group. This is from 2017. And this one's a little bit weirder because it's not a payer, right? It's more of an individual practitioner.
Yeah, we wanted to raise this case. In some ways, there's not a lot to learn here because some of the conduct is things that, are kind of outrageous. But it's important to mention because this is a case where the enforcement was against the provider. And most of these cases so far have been payers. So that's why we just wanted to mention this. In this case, there was a medical group and there was a specific provider, and it's alleged, we don't know all the background yet, but it was alleged that the provider was knowingly putting false diagnosis on the claims. And it potentially, it's a little bit unclear, but potentially wasn't even seeing the patients, was just boosting claims. And so, that's intentional, sort of egregious misconduct. What's interesting is the practice had a coding and compliance committee, and that was actually led by a physician, Dr. David Nutter. So we can imagine that committee was raising concerns. We don't know all the ins and outs of that, but one would imagine that committee was raising concerns that went unheeded by this treating physician. And so as a result, Dr. Nutter became a whistleblower and reported it. And so the government at that point got involved.
That's eternal clinic drama right there.
Very dramatic. Yes. Good point. So, the bottom line is, again, these are diagnostic codes. They come from a physician as a part of their treatment of the patient. And if we follow that, we're going to be okay on this every time. But we do expect to see additional enforcement directly with physicians. As I said, the government thinks there's billions of dollars here of improper billing.
So I think that we should just summarize, what we've learned from these three cases that we've seen, just to, make sure that people are coding properly and thinking about this and taking away lessons.
Yeah. The bottom line here, and we spare you all the detail, it takes us hours and hours of study to get this boiled down. People sometimes say it takes a lot longer to say less. But the bottom line of all of this body of law is that, I've said it several times, diagnostic codes are clinical, they're from the physician, they're part of the treatment. And if we follow that, we're going to be fine every time. The second area is in the work we do in compliance, is that the audits and the quality confirmations that we do over our program are used not only to just boost codes, but also to correct codes. And anytime we know of errors, we have to address them. Finally, we have an open and transparent culture and compliance program here at Village. And anytime anyone has concerns, we welcome their questions and we appreciate them raising them. We want to know and get these things right. so that no one ever feels like they have to go to the government in order to make sure that we're not doing something improper.
Yeah. So, I mean, a big lesson for people who are listening is encourage your employees to report to you so that you can identify and fix issues in your sort of system, so that way they don't feel that they have to go to the government to address these concerns. Right, Wendy?
That's exactly right. And they can report, as we've said many times at Village, we have a compliance program and people can report any number of ways.
Yeah.
So if we look at the bottom line of all of these cases, I would say it's a good time to be at Village MD because our program encompasses all of these elements and more. These are validating to the work that we do. Both our physicians, our clinical teams, our pop health teams are literally obsessed with getting codes right. And so are we in the compliance department. And so, again, it's a good time to be at Village MD. So we appreciate everybody tuning in, and we look forward to coming back with this and other important topics.
Thank you to our sponsor, Village MD. We hope you will join us for future concise compliance conversations.